you can see it later on YouTube. We may follow the live stream tonight of this webinar. I am hanged on. Sorry for that. It is a great pleasure for Saudi Society of Blood Disorder to announce سلامة دمك بالعربي. It's a website mainly directed to the patients and the community. There is a lot of data. It is important for them to know. I hope once we complete this website, any information about hematology people they need, they are going to have it at this website. And thank you to Dr. Firas Al-Freih and the group whom they have created this website. وجعله الله في ميزان حسناتهم. It is my great pleasure to introduce the first speaker, Dr. Munir Al-Bakshi. Dr. Munir Al-Bakshi is one of the senior in Saudi Arabia, and he is interested in the field of sickle cell anemia. He is consultant pediatric hematology oncology at Al-Hassa region, and I believe that he has retired from the Ministry of Health and he has his own private. So Munir Al-Bakshi will talk to us overview and vasculopathy, pathophysiology as an introductory. You have 20 minutes, Munir. Go ahead, please.
بسم الله الرحمن الرحيم. شكرا دكتور فراس، دكتور أحمد على هذه المقدمة, this introduction. I am not yet retired, but I am on vacation so far. I will speak in the next 20 to 22 minutes about sickle cell disease, vasoclusion, pathophysiology. The agenda here, it will be about the epidemiology, the basic pathology, pathophysiology, and I will summarize the issue. When we are talking about sickle cell disease, just 30 seconds about it. That sickle cell disease, an autosomal recessive disorder, and we have two alleles, one from the father and the other one from the mother. One of the alleles should be hemoglobin S. If it is homozygous, it's called sickle cell anemia. When it is a double heterozygous state, then we will have the rest of all these double heterozygous states, and all under the umbrella of sickle cell disease. We know it is a disease of the old world, and because of the migration from the old world to the new world, it became a pan-world disease. And you know, in the United States, around 100,000 patients over there. In Saudi Arabia, we don't know the number because of the registry of sickle cell disease still is growing. Is it between 60 or 90,000 patients? The estimated newborn in the worldwide is around 350,000 being born every year. Here in Saudi Arabia, this is unfortunately a map of a prevalence which is based on one of the studies of premarital screening, which actually will not reflect the total number of the patients, but it is a cross-sectional one for adults going into marriage, which with that Al-Hassa area is having the highest hemoglobin S, followed by Jazan, then areas in the west, and the least is the north, followed by the central regions. This map, it showed the clear correlation between malaria area thousands of years ago and sickle cell disease, and that we see that Saudi Arabia is among those high prevalence of S gene or S allele frequency. In the past almost 100 years from the discovery of sickle cell disease in 1910, there was a good progress in the diagnosis of sickle cell disease from and the management, which is the breakthrough. It was in 1998 with hydroxyurea, and in the past, then there was a pause of almost 35 years from the management until the year 2017, where FDA approved the use of L-glutamine, zenocruzumab, and fixolator in the year 2019, and just yesterday, the CRISPR gene modification or gene therapy was approved for sickle cell disease in the United States of America. Sickle cell disease in Saudi Arabia, history going back to the 1963 by Dr. Lehman. This is the first paper in Nature. When Aramco Health Center discovered a group of patients that these are the patients based on the villages and if they are urban or living in desert. This is the first distribution of hemoglobin S in Saudi Arabia. As I mentioned, it is autosomal recessive disorder. That means we should have at least 2 carriers of parents to have a pregnant lady, and we have 25% chance of the pregnancy to have a sickle cell disease, where the 75 either they are healthy or they are sickle cell trait. Why we are talking about vaso-occlusion? Vaso-occlusion is the tip of the iceberg of sickle cell disease and the hallmark of sickle cell disease when it manifests as pain. And we know that the vaso-occlusion is not only pain. Pain is the thing which bring the patient to healthcare professional. But below the vaso-occlusive crisis, there is a cascade of events that occur beneath the surface. Again, pain is not something easy. We know that sickle cell disease in the past being treated as acute disease. Really, it is not. The patients they are growing. In the past, the disease kill the patients when they are young. But with the advance in the supportive care management of sickle cell disease, the patients, they are growing. But we can see that there is a good correlation about pain and mortality. When the patients have more than 4 vaso-occlusive pain per year, it is different from patients who have less, and they can live up to the age of 80. Again, we can see the shift from the pediatric mortalities here. The graph shifted to the right. That means they are growing more into the adulthood, and patients they reach up to 75 and more. And these are different cohorts. This is the old Jamaican cohort that we see that many of the patients they fail their life before the age of 14 years. But with the advances, this is the Boston group that we see that they live more and more with their age. That means the disease change from an acute disease into a chronic disease. And this is why we should dig more and we should learn more. And this is and sickle cell is not a disease which is easy to understand, because the evolution of the pathophysiology was different 20 years ago from the year 2021. So I will speak about the basic pathology of hemoglobin S polymerization, which will lead to the sickling phenomena and hemolysis, the vaso-occlusion, steroid inflammation. The basic pathology here, that in normal DNA sequence, we have this, the bases that produce the normal beta chain of the normal hemoglobin. It produces glutamic acid, which is GAG, the adenine. But because of missense mutation, this adenine will be replaced by thiamine, leading into there is the mutant beta chain, which is hemoglobin S, showing that there is a valine glutamic acid instead of the normal glutamine, which is occur in the 6th position in the beta chain. This is the summary of the pathophysiology. We have the main thing, my topic, is the vasocclusion, and on the other end is hemolysis, but everything is interchanging. And there is interaction, but there is inflammation, endothelial dysfunction, and adhesion which occur. And all of them will lead to end organ damage, unfortunately, which will start early in age in sickle cell disease. Now, I will talk about the vaso-occlusion pathophysiology, the primary lesion, the adhesion, inflammation, virology, and viscosity. The topic is dry, little bit is difficult, but I hope that I will make it more digestible and in summarized form. This is the normal hemoglobin S inside the red cell. This hemoglobin S is swimming. They are not attaching to each other, and it is in the R quadriform form. But when under stress condition, what will happen? There will be this deoxygenation, and there will be stickiness of the red cells, the hemoglobin S to each other. It will be condensed and became a polymer. And this polymer, the nucleus, it needs at least 30 million molecules. If we remember that we have almost 250 million hemoglobin molecule in each red cell. And there are conditions that affect this polymerization. One of them is the characteristics of hemoglobin S. This is the normal oxygen dissociation curve. This is the normal, and this is the sickle cell trait oxygen dissociation curve, and this is hemoglobin S. We know that hemoglobin S is shifting the oxygen dissociation curve to the right. That means the affinity is less to the oxygen, and the easy delivery or premature delivery of oxygen under any stressful condition. That means the shape of the beta S or the hemoglobin S will be changed from the R state into T state. Then it will be a cascade of events that I mentioned. The polymerization occur, then it will affect the cell membrane. There will be the water inside the red cell will go out, then the cell will be dehydrated to become rigid, and the membrane will be damaged. And after damaging, then the hemolysis can occur. Now I will talk about the multicellular adhesion. The adhesion is very important here, and the adhesion molecules, they are more in sickle cell disease patient, whether the patient in the normal state or in the crisis or stressful condition. But during the stressful condition, these adhesion molecules, which are, it is a big family of vascular adhesion molecules, whether VCAM or CD13 or alpha-4 beta-1 integrin, they are playing very important role. But it will start with the white blood cells and the endothelium. There is interaction between the white cells. They have many roles. The first one is the rolling effect. Those cells, they are playing and they are being rolled, and there will be an exposure of the sites of adhesion. This is very important, or they are called the selectin. And we have two types of selectin. Those are proteins. I will speak about them later briefly. This is B-selectin, and we have E-selectin. These are in the lining of the endothelium, and it will attract the white cells, which has the receptors, and they will become sticky to each other and to the endothelium. And because of the polymerization that occurred early on, the sickle RBCs, they are hydrophobic. They have hydrophobic interactions, and they will collide together. And because of the adhesion molecules, the selectin on the white blood cells, these cells will be attracted. Later on, this one will be exacerbated more and more because of hemolysis and the release of the cytokines and chemokine. Then these cells, again, with the interaction of those cells of the platelets again, which has again B-selectin, and they will accumulate to each other to occlude the small capillaries here, and the blood flow will not go through, and there will be a consequence of ischemia to the tissue. This is in a brief. So, and we have to concentrate on B-selectin because it is having the maximum role in sickle cell adhesions. Now, with the selectin, they are a family of cell adhesion molecule. They are CD62. They are single chain transmembrane glycoprotein, which share the similar property to the C-type lectin deuterated amino acid terminus, and they are calcium dependent binding. And there are three types or three subsets of selectins. The A-selectin on the endothelium alone, and L-selectin on the leukocyte, and the B-selectin, they are on the platelets and on the endothelial cells. And they are very important because this thing have implication when we are when the subject about targeted therapy against those selectin to improve the adhesion molecule or adhesion state in the pathogenesis of vasocclusion. Selectin, they don't have one function. But in sickle cell disease, it is the main domain of adhesion, but it is having an important role in the lymphocyte homing, in chronic and acute inflammatory process, which include the post-ischemic inflammation in muscles, kidneys, heart, skin, atherosclerosis, glomerular nephritis, lupus, and even in cancer metastasis. And this is why they are very important molecules. Now, when we are talking about inflammation, the inflammatory process could start even before the adhesion, but the adhesion will progress, then the inflammation will take place, and it is the one which will propagate the adhesion more and more. It will start about this chemokine, which is one molecule from the cytokines, which is very specific. It attracts the neutrophils to the red cells and to the endothelium. And after this activation, more adhesions will occur until this process will be broken. The sickle cells, they are usually activated, as mentioned, in the endothelium, then in the blood vessel in the capillary itself of the small blood vessels. Blood viscosity again play a very important role in the vasoocclusion, and it can result from the chronic hemolysis and reduce sickle erythrocyte deformability because these cells are rigid because of the intracellular polymerization. And the inflammation and inflammatory process or environmental factors can are the one which can trigger the vasoocclusion, either infection, hypoxia, dehydration, acidosis, or even unidentified factors. Patients, they present without a precipitating factor. And it can cause the acute systemic painful vasoocclusion crisis. And at the same time, it can send the stimuli, the noxious stimuli to the brain, which will be expressed as pain. Now, when we are talking about blood viscosity role in the vasoocclusion, we have the shear force or rate and the viscosity. They are opposite each other. When we are talking about the normal red cells or normal hemoglobin, that we will see it is having more shear. The rheology is of the cells is very nicely moving. The RBCs, they move very easily. But when either you have high hematocrit or dehydration or damaged cells, then you have those cells, they are the sickle cell, the viscosity of the blood will increase. And these are the studies, they are just lab or animal studies. It wasn't studied on a human being. At the same time, we can see the sickle cell hemoglobin in the normal status or steady state, or a different level of all these, they are sickle cell. But you can see that the elongated one, the sickle cells, they have more, they have less shear force, and that means they have more, they cause more viscosity to the blood. And there are factors that play a very important role, either the haplotype, that we need that the Benin type or Central African haplotypes, their blood, they are more viscous. And there are other factors that play a role, which is like hemoglobin F. When it is increased, it will reduce the viscosity by increasing the shear force. Oxidative stress.
2 more minutes, Dr. Mulin. 2 more minutes.
Now I will talk about the summary of the events of vasoocclusion. We have the sickle cell after becoming polymer and the RBC bindings, then the aggregation of the cells, the white cells and the red cells, then the selectin expression to attract them, then because of the chemokine and the inflammatory process, there will be exacerbation of those cells. These events, they are interacting, so the polymerization, the vasoocclusion inflammatory process, they are, and later on the cause of endothelial dysfunction, and the polymerization will lead to hemolysis and the sickle cell phenomena. We know that we have trigger factors that can be either they are patient factors, environmental factors, or the patient having comorbidities that precipitate the vasoocclusion. Biomarkers, it is very important here, and many studies, either in the lab or human, to identify the biomarkers that identify which patient will be at risk of the vasoocclusion. Again, genetics modifiers or predictors, they are very important in the place, but unfortunately, I have only 20 minutes. What are the clinical implications of vasoocclusion? The acute pain, acute chest syndrome, diastolic cardiomyopathy, retinopathy, acute hepatopathy, splenic infarct, mesenteric ischemia and infarction, avascular necrosis, and fat embolism. These are the main syndromes caused by vasoocclusion. These are the cascade or the phases of the pain crisis. And this is the last slide to show that we have, or many studies that I have collected and summarized to show what are the predictors of vasoocclusion and pain severity, even in the neutrophils, the platelets factors, the level of hemoglobin F, co-inheritance of alpha thalassemia, low hemoglobin D, vitamin D, extracellular hemoglobin because of hemolysis after consumption of the hepatoglobin, and reduction in nitric oxide, and very importantly, lactic dehydrogenase, which is in our hands measurement. So I will summarize my presentation. Polymerization is the central event because it is the primary lesion. Similarly, when we are talking about bone complex and TB, we are talking here about hemoglobin S polymerization, which the trigger for the events and the vascular injury in the endothelium. Again, the genetics factors is polymerization, independent hemolysis, and it can exacerbate sickling and vasoocclusion in this cell. And organ dysfunction, it starts very early in life. Building sickle cell disease care capacity should be started very soon and distributed with to all, and will be available to all the patients by trained healthcare professionals through either like this event or others to be applied on the real life in our patients. And I think this is my last slide, Dr. Ahmed Yorashmit, in 20 minutes. And thank you for your being patient with me. Thank you very much.
Thank you, Dr. Munir, for this kind and very informative presentation. I believe Dr. Yasser Wali has some technical issues. While we are waiting for these technical issues to be sorted out, it's my great pleasure to introduce Dr. Hafez Malhan. Munir, can you stop sharing, please?
Okay.
Dr. Hafez, are you ready to present? Dr. Malhan. Yeah, yes. It is my great pleasure to introduce Dr. Hafez Malhan. He is consultant hematologist from Prince Mohammed bin Nasser Hospital at Jizan, and he has contributed in a lot of committees in Ministry of Health, and he has part of guidelines and some guidance for the sickle cell in Saudi Arabia. Dr. Hafez, he will talk to us about acute painful crisis. Dr. Hafez, تفضل.
Assalamu alaikum, bismillah, salatu wassalam ala rasulillah. Thank you for invitation, Dr. Faraz, Dr. Ahmed Tarawa, and for the organizing committee. I remember last year in Mayo, we present this, not the same topic. We talked about sickle cell anemia, but it was in Arabic presentation. It was good experience. Today we are talking about acute painful crisis in our patient. As a start, introduction. So acute painful episode in sickle cell anemia patient usually develop a result of VOC, vasoclose crisis, as mentioned by Dr. Munir, and should be treated as medical emergency. Before painful episode or painful crisis, it was named as vasoclosive crisis, and recently the term was changed to acute painful crisis or acute painful episodes, as it's represent a part of vasoclosive crisis pathophysiology. Acute painful episode is the most clinical presentation in our patient in acute and in chronic, in acute settings, and in the chronic settings also the patient, a lot of them, they complain in the clinic with chronic pain. It is associated significantly with morbidity and mortality, as mentioned previously in Dr. Munir, and significant decreased quality of life if not was managed properly. I will show you this study. It was done in our region by Dr. Ahmed Hazazi, medical intern, and his colleagues. It was conducted in 2018 in 4 hospitals in Jizan. Studies the epidemiology and characteristics of sickle cell patient admitted to the hospital, conducted in 4 hospitals with a total number of 446 patients. And the main finding in this study was the incidence of sickle cell anemia admissions, and it represented up to 25% of this admission in all 4 hospitals. as compared to other diagnoses. And those patients who present 25% of admission, the main characteristics of admission, or the main reason for admission, was painful crisis, represent up to 58%. That was followed by acute chest syndrome in 14%, cholecystitis and gallstone complication in 6%, and so on. So vasoclosive crisis or acute painful episode represent up to 60% in those patients with major impact in the healthcare sector. I found this slide very representative of acute painful episodes as a part of vasoclosive crisis. The iceberg on the top only represent the painful episode, while in the bottom represent the fatal or the related fatal complication associated with painful crisis. So the patient, when admitted, we think it's simply painful episodes, but in reality, he has a lot of major complication that may end in significant mortality, morbidity, and may end in death certificate will be the outcome in some cases. So acute chest syndrome on the top of this complication that represent up to in 50% with acute chest syndrome preceded with painful crisis, followed by acute multi-organ failure, sudden death syndrome, acute surgical abdomen, acute papillary necrosis, and delayed hemolytic transfusion reaction, and VTE, DVT, or pulmonary embolism also has a major presentation in our patient, or as a major consequences in those patients. I found this table is very interesting and up to date. It summarizes acute presentation of sickle cell disease complication that often presenting with pain. One of these is multi-organ failure in a patient who has history of chronic pain, lung disease, renal insufficiency, those who may present with fever, increased respiratory rate, increased heart rate, blood pressure changes either high or low, with non-focal neurological changes. And the pain is so often severe with rapid organ failure. And you will find significant decrease in hemoglobin, platelet, increased bilirubin, coagulopathy, and signs of rhabdomyolysis and infiltrate on chest X-ray. Hemolytic transfusion reaction also is represent in cases of alloimmunization due to recurrent blood transfusion. CNS crisis has also some presentation in these cases. Return to our study, they found up to as complication or presentation of our patient, VOC represented up to 90% of complaint in those patients, and followed by acute chest syndrome, as mentioned, in 60%. And as all of you know, that 50% of acute chest syndrome preceded by painful crisis. And unfortunately, that acute chest syndrome represent cause of death in 25% of patients with sickle cell anemia. Sorry for this slide, little bit complicated, but to explain the interaction between or interrelation between vasoclosive crisis, pain crisis, and acute chest syndrome. So after triggers of the vasoclosive crisis or sickling by precipitating factors that result in vasoclosive crisis that cause bone marrow infraction that result either in fat embolism and will result immediately to acute chest syndrome, or result in pain in the back, long bones, and rib infarction that will result in hypoventilation that also has a contribution by narcotics that we give if the patient exposed to toxicity. Hypoventilation results in atelectasis, result in hypoxemia, and the cycle is continue with vasoclosive crisis and acute chest syndrome. So please, is not a simple painful crisis, is not a simple VOC, it hides a lot of complication. So what are the characters of the pain? The pain episode can begin as early as 6 months of age and typically last throughout the life. So there is a strong recommendation in pediatric group to start hydroxyurea for patient at age of 9 months. It's a tense pain with other variable forms of the pain, and that's present in next slide. This was done in 1993. The description of pain, it was showed in many different shapes, mostly as a throbbing pain in 68, sharp pain 37, dull 15, stabbing 12, and so on. So most of the patient describe it as intense pain. It's range from mild to debilitating, and duration can last from hours to days. They found in the study the most or the average for the stay for the patient with acute painful crisis range from 9 to 11 days. Another description of the nature of the pain reported by mother with sickle cell disease as severity is more than pain of labor. Locations common include the back, chest, abdomen, and long bones, and infants is represented mainly as dactylitis. Another challenges of pain is neuropathic pain that mainly or likely underdiagnosed in those patients, and it includes components of central sensitization, peripheral nerve injury, and or hyperalgesia, and in most of the cases increase with age. What are the triggers? I mentioned before, infection, one of the most triggers of the acute painful crisis, extreme cold or heat exposure. Another factor that I found it very common in our patient in the clinic. Dehydration also has a role in exacerbating of the crisis. Heavy exercise also for those patients interested in sport. Another two things I should highlight included smoking. And unfortunately, a significant number of patients, they have this habit, and it increased the painful crisis as well as increased the incidence of acute syndrome. And in other study in Turkey was done that showed patients who are smoker, they have autosplenectomy up to 16% versus 9% for non-smoker. Stress and decreased sleeping time is very important, especially for the patient has not committed to a job. They will have some sorts of stress and insomnia. Menstrual cycle is very important to explore it in the OPD visit for the patient or even in the emergency visit for the patient. And usually the ladies, especially the young ladies coming to us from pediatric, they shy to mention it, and you need to explore specifically. And I found it in the clinic, it responds significant to hydroxyurea if they are compliant to a proper dose of the hydroxyurea. Red flag for this painful episode, we should have a good attention to it. We should ask about the pain nature, if there is any atypical pain in severity or location, that we need to explore the reason for this. They may have acute vascular necrosis of the joint, they may have osteomyelitis, or they may have rib infarction that may result in other complications like acute chest syndrome. Abnormal vital signs that may indicate infections. Abnormal labs, they may present with leukopenia or leukocytosis that we need to explore as a result of infections. Worsening anemia that may result from exacerbated hemolysis, and bone marrow suppression as a result of some infection like parvovirus infections. Decreased retic count. Usually those patients have high retic count. Little high retic count, and when you found decrease, so we need to thinking about bone marrow suppression. Abdominal pain, distension, it may represent as a complication of sickle cell anemia therapy in cases like iron chelation therapy, or may represent bowel ischemia, bowel infection, or sequestration. Acute syndrome initially, and
I think Dr. Malhan has an internet issue.
Assalamu alaikum, Dr. Ahmed.
Ahlan, Dr. Yasser, how is the situation at your side?
No, it's okay now. Alhamdulillah.
Okay. Okay, probably while Hafez, he's coming back.
Okay.
Hafez, can you continue? Hafez? Well, let me shift to Dr. Yasser while we have this problem. Maybe the weather issue in all over Saudi Arabia nowadays has something to do with signals. Sorry for that. It's my great pleasure to introduce one of the eminents in the GCC, and he is the friend of many of us. I am one of them. Professor Yasser Wali, he is professor of hematology and consultant.
Hello, Dr. Ahmed. Sorry, I have some technical issues. Hello, do you hear me?
He came back.
Yes,
Hafez came back.
Hafez. Yes, Hafez.
Yeah, Dr. Ahmed, yes. Do you hear me?
You can continue, or still you have a problem?
Yes, I can continue. We have some, as mentioned, weather changes, connection a little bit poor. I can continue. I am maybe the last 2-3 slides.
Yes, please.
Is it okay?
Yeah, go ahead.
Okay. So pregnancy, more red flags for patients with pregnancy and post-operative. They are high risky to have more complication on admission due to painful crisis, non-focal neurological changes that may represent multi-organ failure. Line of management. So it's very important to recognize the nature of the pain and discriminate between other causes of causes that present or that cause a painful crisis. You need to discover the triggers of the crisis of this episode, and those patients need rapid triage in less than 15 minutes. Clinical pain assessment is very important. Analgesic administration must be given immediately in less than 30 minutes. Adjunctive therapy, it will help to reduce the episode, and some therapy to be avoided or minimized, and also need to plan to prevent future attacks. So clinical assessment, you need to believe the individuals and or family self-report of pain and rapidly assess pain location, quality, duration, and severity, and assess potential comorbidity that cause pain like AVN, osteomyelitis, rib infraction, compression fraction. And I have interesting story with my colleague, Dr. Bakar. He found one case have been treated for few months as acute painful crisis, and it was actually osteomyelitis. Need to assess potential comorbidities, as we mentioned, chronic organ dysfunction like strokes, infection, acute syndrome. Analgesic administration, need to utilize the proper score, as most of the patients they present with high score and they require opioid. Immediate administration less than 30 minutes to reduce the intensity of the attack. Paracetamol and nonsteroidals, it's used for mild cases. IV morphine, IV hydromorphone can be repeated every 10 minutes or every 20 minutes. Close monitoring and assessment of response, and medication side effect, and morphine repetition as mentioned. Adjunctive therapy is very important. Aggressive hydration is very important for those patients and should be close monitor for the hypervolemia. Heat packs and use of ketamine is found beneficial for our patient, treat insomnia and sleep disorder, treat constipation as secondary constipation of narcotics, psychological and family support, and very important to continue hydroxyurea during the admission unless there is contraindication. VT prophylaxis, especially for those patients more than 18 years or older, they have to be in VT prophylaxis if there is no contraindication. Blood transfusion really we used for acute painful crisis, but in some cases, as we mentioned, if there is bone marrow suppression, if there is hemolytic crisis associated, need to be considered. Incentive spirometry, it was found in the different study have a good or significant reduced rate of developing acute syndrome. And usually we use for our patient, although it's difficult complaint to our patient for incentive spirometry. Increasing knowledge for your team, for your patient about situation that precipitate the crisis and potential complication of this presentation. You need to teach also your patient about the importance of incentive spirometry and teach nurses and other staff about disease management. Convince your pharmacist about the importance of narcotics for painful crisis, as we have been some experience of some resistance from our colleague in pharmacy. ICU staff awareness is very important about immediate intervention in cases of complicated pain crisis like acute chest syndrome or non-focal changes as a result of multi-organ failure. And you need to be ready for exchange transfusion for reluctant cases. Challenges are there, yes, for those patients, drug-dependent patients, and we have a lot of conflict in management for those patients. And we may need to talk about in other session. Compliance to treatment is very important in our patient. Some our significant patients, they don't comply to hydroxyurea, but they ask always for narcotics. And this can be overcome by continuous education. Iron chelation also is very important for them. Drug-induced complication, sometimes that you have hydroxyurea side effects like thrombocytopenia, leukopenia, and you need to look other options like the new modality of drugs that have been approved for sickle cell patient. Reluctant cases, you need to rule out osteoporosis, bone infraction, osteomyelitis, neuropathic pain, all these to be considered. And pain surface management, most of the time not available in our hospital, and bone marrow transplant that is not available, maybe not available, especially in our region, that we need to have a good connection with center in Riyadh or Jeddah. And thank you very much for their help, Dr. in King Faisal Specialist Hospital and National Guard Hospital. They are helping a lot. Plans after discharge, education about 3 important things: prodromal symptoms. That's very important to educate the patient to start treatment in the prodromal symptom, not at the start of the symptoms. Teach them about compliance to treatment and avoid triggers as much as they can. After discharge, the patient please refer to the hematologist and improve lifestyle for them to decrease the attack of the crisis, and refer to psychiatry if needed, because there is significant of our patient, they have some element of depression. Refer to pain surface if it is available in cases of neuropathic pain. They will help a lot in this matter. Blood exchange for reluctant cases, I found it very helpful to our patient. We are providing it every 3 to 4 months in our patient, and it's very significant. New medication have been approved: Kirizanlizumab, Fluxetor, L-glutamine in the era now, and we hope that will be available very soon. Just the last slide. This represents the prodromal phase before initial phase of acute painful crisis. Is very important to teach our patient to start treatment here, to start have a rest, to avoid triggers, take more fluids, and in some patient I advise to start paracetamol just to to decrease the intensity of the attack. Thank you very much, and so sorry for the technical errors that have, and thank you for the attention from everyone. Thank you.
Thanks a lot, Dr. Hafez. Again, Dr. Yasser Wali, he will talk to us about the transfusion update in sickle cell anemia. Dr. Yasser, he is a consultant pediatric hemong and the professor of hematology, Sultan Qaboos University, Oman, Muscat. Dr. Yasser.
Assalamu alaikum wa rahmatullahi wa barakatuh.
Salam.
Dr. Ahmed Tabawa and my colleagues. Are my slides seen?
Yes, Yasser, go ahead.
Okay. So thank you, Dr. Ahmed, for the kind introduction. After the two speakers already has a very good presentations on sickle cell disease, my role now is to talk about the role of anemia and hemolysis in organ damage in sickle cell disease patients. And actually, it's quite an old and new topic. This is the place where I work in Sultan Qaboos University, and I'm not going to spend time on what already have been said, like that the single mutation or the point mutation in one of the beta genes will result in substitution of glutamic acid by valine, and this will result in what we call the hemoglobin S. If we have it on two genes, then this is a sickle cell anemia, or we can have also S and beta thalassemia, or SC, we call that a double heterozygous. So our concept for years has challenged now. What was our concept for this disease? That the main pathophysiologic mechanism of sickle cell disease is vaso-occlusion. This has been valid for years. However, it has been recently challenged for so many reasons with so many evidences, as I'm going to discuss in my in the coming 20 minutes. So there are many recent evidences from research studies and the clinical trials that the main drive behind all the pathophysiologic mechanism, clinical manifestations, complications, and end organ damage in sickle cell disease, and even mortality, is chronic hemolysis. Chronic hemolysis results usually in chronic inflammatory state and activation of coagulation. If we remember from our basic studies when we were medical students, that sickle cell disease was under chronic hemolytic anemias in the textbook. It is also worth mentioning that in sickle cell disease, the lower the steady state hemoglobin, the worse in general is sickle cell disease. And this has been our observation for years. We know that the central pathophysiology, and has been explained nicely by Dr. Munir, about that the main thing in sickle cell disease is the hemoglobin S polymerization and the sickling during the oxygenated state or hypoxic states. So hemolysis and anemia actually is the start of this. Hemolysis and anemia will lead to oxidative stress, will lead to free hemoglobin and heme. This will reduce an important substance in our body, which causes vasodilatation. It is called the nitric oxide. So the nitric oxide will be reduced, and also some red blood cell membrane damage will happen, resulting in some factors. All this will end into a triad of inflammation, endothelial activation, coagulation, and at the end, vasocclusion. So the process starts with hemolysis and anemia, and then end by vasocclusion. Collectively, all this together will lead to end organ damage, as we can see later. So chronic hemolytic anemia leads to vascular injury and the progressive end organ damage. So the sickle cell disease, what are the manifestations of the main consequences of the hemolysis? Are the chronic anemia, hypoxia, neurocognitive damage and strokes, pulmonary hypertension, nephropathy, priapism in males, leg ulcers, and systemic hypertension. However, the vaso-occlusion, as we all know, it leads to the acute pain crisis, chest syndrome, retinopathy, hepatopathy, splenic infarcts, and avascular necrosis. It is also important to note that the byproducts of hemolysis causes chronic inflammation and activation of coagulation, as already highlighted. And this will have a very important role in the vasoconstriction. Clinically, this hemolysis and the lower steady state hemoglobin will increase the risk of serious complications in sickle cell disease. Like, for example, increase the high transcranial Doppler velocity values, stroke, silent infarcts, pulmonary hypertension, and increase the tricuspid regurg velocity, nephropathy and kidney disease, priapism, and leg ulcers. Meta-analysis of 41 studies that showed that when the hemoglobin is significantly lower in children and adults with clinical complications of sickle cell disease. So a reduction in the steady-state hemoglobin in sickle cell disease patients will result in a higher risk of elevated pulmonary artery systolic pressure, pulmonary hypertension, albuminuria, nephropathy, abnormal transcranial Dopplers brain velocity, and silent strokes or overt stroke, and even death. So mild to moderate reduction in hemoglobin may be of major clinical significance in patients with sickle cell disease. This is very important information, and a recent meta-analysis published in 2020. So the complications of sickle cell disease, we should realize that these complications start from childhood and then progress in adulthood. So even young children with sickle cell disease, as young as 9 months, they can start the complications of sickle cell disease. And if you remember the sickle cell study group, large trial on the baby hack trial, they started hydroxyurea on the age of 9 months because of that. So we might have, I'm not going to repeat what have been said, but some neurocognitive impairment, cardiac, liver and renal, priapism, and all the others. And these complications will go throughout the adulthood, and in adulthood we might have pregnancy-related complications. The leg ulcers are obvious, and the AVN with reduced bone density, plus all the complications that happened in the childhood. Specifically, I would like to stress on the neurocognitive impairment and the pulmonary hypertension, chronic lung disease, etc. So anemia and hemolysis are associated with progressive damage to the organs. So particularly in patients who, the adult patient by the age of 40 to 50 years, they might have a very serious organ damage or even earlier. The main organs of the body can be affected: brain, lungs, heart, liver, spleen, kidneys, penis, and the skin. So in summary, from all these trials, that sickle cell disease, nowadays we look at it as from an acute episodic condition or vaso-occlusive crisis of the young to a chronic progressive inflammatory disease of the adults. It's a state of chronic hemolysis and chronic inflammation. So as children live into adulthood, individuals with sickle cell disease are facing increasing burden of end organ damage, which leads to poor quality of life, high morbidity, and even early mortality. As we mentioned before, hemoglobin S polymerization is the central event of sickle cell disease, which leads vascular injury, and anemia and hemolysis play an important role in hemoglobin S polymerization. They also play an important role in development of end organ damage, and the progression of organ-specific vasculopathy often precedes a clinically evident organ dysfunction. And it is now also clear by many studies that the end organ damage starts early in pediatrics, but is not clinically evident until adulthood. The most important message here is once end organ damage is present, it will be very difficult to reverse. So we have, as pediatricians and pediatric hematologists, to act fast to prevent this as early as we can. This is a recent trial, not a recent, actually, it's 2014, on the quality of life of patients with sickle cell disease, and you find that the quality of life is significantly reduced because of the pain, because of the mobility impairment, because of psychosocial, but also because of the general function like cognitive impairment, limitation in daily activities, difficulties with employment, and so on. Now we are going to discuss the effect of this hemolysis and reduced steady-state hemoglobin of the anemia on the main organs we talked about one by one, and discuss the trials. So Elliot Vishensky in JAMA in 2020 published a very interesting article about the cerebral vasculopathy, and they mentioned about that when you have anemia, it reduces the oxygen delivery to the brain, and this will decrease the cerebral vascular reserve, and this severity correlates with abnormal TCV. And the hemolysis will release cell-free hemoglobin, which is scavenger nitric oxide, and facilitate oxidative damage and damage to the vessel. So all of them will result in cerebral vasculopathies with increased risk of stroke, silent infarct, and neurocognitive problems. So this has been shown in many recent studies that the role of anemia and hemolysis on cerebral vasculopathy is very obvious. Again, if you look into this graph, that the lower the hemoglobin level, there is increased risk, of stroke and silent brain infarct. And you can see even small drop in hemoglobin will result in a higher risk of stroke and silent cerebral infarction. In these studies in front of you, we can see only 0.6 or 0.7 reduction of the mean hemoglobin. Also, the hemolysis will increase the risk in children with sickle cell disease. If you look, and also of the time to stroke in subject is stratified according to the absolute reticulocytic count in this very interesting study. So absolute reticulocytic count is a marker of hemolysis. Whenever you have a higher absolute reticulocytic count, like in this curve, then there will be a higher probability of having the stroke in the children. And whenever the absolute reticulocytic count drops to normal, then you will have a much lower probability of developing stroke. And this subject have been followed for a median of around 11 years. Then the same, anemia and hemolysis has both an important role in pulmonary hypertension. The anemia causes increased cardiac output secondary to anemia, and also the hemolysis will lead to impaired vasodilative responses to nitric oxide. There will be free plasma hemoglobin, higher lactic dehydrogenase, and all of this will contribute to pulmonary and systemic vasoconstriction. I had one child who is 14 years old with sickle cell disease with low steady state hemoglobin of around 7. And he developed, actually with high reticulocytic count, he developed pulmonary hypertension at very young age, at the age of 14 years. So we have to identify these patients as early as possible and try to intervene before they develop the irreversible organ damage, or like pulmonary hypertension. Once it develops, it will be very difficult to correct. Again, they did the same study about the reticulocytic count, and whenever you have higher reticulocytic count, then you will have the tricuspid reverse velocity as a surrogate marker of pulmonary hypertension will be increased. So there will be increase of the tricuspid reverse velocity with reduction of hemoglobin and with increase in the reticulocytes. Both of them, they signify hemolysis and anemia. Also, The same in adults with adults with sickle cell disease. They will have higher risk of increased elevated tricuspid regurg velocity. If you look here, it is also by the lower hemoglobin level and also the higher total bilirubin. So the total bilirubin again is a surrogate marker. Higher total bilirubin is a surrogate marker for hemolysis and anemia. And in this study, it was not only on sickle SS genotype, but also included SC, S-beta node, and S-beta plus thalassemia. So almost all genotypes of sickle cell disease showed the same risk of pulmonary hypertension when they have more anemia or less steady state hemoglobin or higher bilirubin levels. On the kidney, again, there are a recent study in 2015 which highlighted that progressive renal vasculopathy and the progressive kidney disease state is related to also anemia and hemolysis. The hemolysis will release heme, which facilitate oxidative damage and effect in renal vasoregulation, and also the anemia will result in compensatory increased cardiac output, resulting in renal hyperperfusion and glomerular vasculature. At the end, the more anemia you have, the more hemolysis you have, the less hemoglobin you have, the more renal vasculopathy and the famous sickle cell disease nephropathy will happen, and it might happen earlier. Again, in this study, they have shown that all the markers of hemolysis, like the higher LDH level, higher reticulocytic count level, and the lower hemoglobin level are associated with more microalbuminuria. So lower hemoglobin levels, higher LDH, and higher bilirubin in children with sickle cell disease are associated with microalbuminuria, which is a strong marker of glomerular damage. Again, in adults, these have been also proved by the lower hemoglobin level and the higher bilirubin level. So you expect, after discussing the role of anemia and hemolysis in patients with sickle cell disease with the end organ damage of the main vital organs, that also what will be the end result? The end result, these are the predictors of death in sickle cell disease. So a lower hemoglobin, if you look into the left side of the table, a lower hemoglobin, even if the patient was on hydroxyurea, a higher glomerular filtration rate, presence of pulmonary hypertension, presence of central venous cardiovascular event, and pain crisis in the past year, all of them are associated with, these are considered predictors of death in sickle cell disease. There's also presence of the leg ulcers, but to quite lesser extent. So the lower hemoglobin level is associated with how it is a predictor of death in sickle cell disease, plus all the complications which have mentioned that these complications result from chronic anemia and hemolysis. The Kaplan-Meier curve, the study confirmed in this study that the known predictors of mortality in sickle cell disease include markers of cardiorespiratory dysfunction, renal impairment, and if you look also that hemolysis as well as the admission rate. So on the left-hand side, you can see the multivariate regression analysis of hemoglobin SS and hemoglobin S-beta node thalassemia. You can find the higher admission rate, the higher creatinine level, and aspartate transaminase as marker of hemolysis are all associated with higher, are all predictors of mortality in sickle cell disease. Again, the same in this trial, the Kaplan-Meier analysis, time to death in the sickle cell study group, subjects stratified according to absolute reticulocytic count. You can see that the higher the absolute reticulocytic count, in this case above 300, is associated with the higher higher risk of death in sickle cell disease patients. And absolute reticulocytic count is, of course, a marker of hemolysis. The same in adults, but they used a surrogate marker of hemolysis in this study of the LDH. We know that lactic dehydrogenase is a marker of hemolysis. So the higher LDH, actually, there's a significant reduction in the mortality. Increase in the mortality. So the Kaplan-Meier curve, you can see that the survival is much less in patients with higher LDH. So, what are my takeaways from this presentation? This is actually Majlis al-Jinn in Oman, and nowadays we are not visiting any of these sightseeing because of the pandemic. We hope that it will finish soon. Advances in understanding pathophysiology of sickle cell disease has changed its paradigm. Hemoglobin S polymerization and red blood cell sickling are the root causes of pathology in sickle cell disease that lead to anemia, hemolysis, and subsequently vaso-occlusive crisis. Studies have found that, I showed you so many studies, that chronic anemia and hemolysis are associated with progressive sickle cell complications like stroke, silent cerebral infarct, kidney damage, pulmonary hypertension, and decreased life expectancy and death. Studies also have demonstrated that anemia and hemolysis are associated with organ damage, which is the major cause of death in people with sickle cell disease. So, final message is the end organ damage in patients with sickle cell disease can happen as early as young childhood, and our duty as pediatric hematologists and pediatricians is to recognize them earlier and to try as much as we can to try to avoid and to correct this anemia and hemolysis and reduce the end organ damage in this patient before it happens, because as I told you before, that the end organ damage can be, once it happens, it is irreversible. With that, I would like to thank you all for listening, and I didn't cross my time. Thank you very much. And
thank you for questions. Thank you, Prof. Yasser, for this excellent and informative presentation. I will be sad if I don't see the title in your presentation. Alhamdulillah, I have seen it. Thank you all the speakers for this very interesting overview, and let us go for the discussion. And the first question to Hafez, Dr. Hafez Malhan. There is a lot of question about the management of pregnancy in sickle cell anemia, particularly painful crisis during pregnancy and the use of opioid during pregnancy.
It was found morphine can be used in small doses or limited doses for those pregnant patients. In addition to other management, as we mentioned, adjunctive therapy like aggressive dehydration, like this. So it can be used. Yeah.
Does sickle cell anemia get worse with age, Hafez?
Yes, yeah. Especially for those patients who are not compliant to proper treatment like hydroxyurea. I always advise my patients, if you take hydroxyurea at the age of 40, you may stay at age of 40, your organ functions. But if you don't take hydroxyurea, you will be at age of 40 like someone who is aging at 70 or 80. So please take it hydroxyurea to keep your organs functioning well.
How we prevent addiction for those sickle cell anemia whom they have frequent painful crisis? Hafez.
Yes, I found very common in our area, especially before before the service established in our region in 2014. After that, we have good education in our clinic. We have good protocol like blood exchange, automated exchange every 3 to 4 months. We have bone marrow transplant we send to our colleague in Riyadh and Jeddah. There is a good reduction in the incidence of addiction, and the people became more aware about other options or the proper treatment actually to avoid the addiction. So education is very important for those patients.
Thank you, Hafez. Dr. Yasser, question: what is the differential diagnosis for a sickle cell patient whom he present with acute hemolytic attack plus D-dimer of 20 and thrombocytopenia with no pain manifestation?
So acute hemolytic anemia with thrombocytopenia and high D-dimers?
Yes.
Acute hemolytic anemia, so the patient is not G6PD deficient. We know that it might be a microangiopathy. I mean, I can see that this might be a microangiopathy. I would like to see his renal functions as well, because we know that acute hemolytic anemia associated with thrombocytopenia, usually we think of microangiopathy. But I want to know the spleen size. I want to know also the renal functions to put the main differential, the differential diagnosis. An acute drop in hemoglobin and a drop in platelets, we can have it also in splenic sequestration. I'd like just to comment on what Dr. Hafez said about the use of hydroxyurea in sickle cell disease as early as we can. This is a very important message. However, we usually find a very good response in regarding the painful episodes. So the painful episodes will be reduced easily, and even we published that in our large group of patients. We used lower doses of hydroxyurea. But in order to correct the anemia or raise the hemoglobin or reduce the reticulocytic count, we need much higher doses of sickle cell disease. And sometimes we don't. So we need sometimes up to 30 milligram, and some of our patients will not manage to take 30 milligram per kilo. I mean, to take that much amount. So for hydroxyurea use, it should be used early. But when you have hemolysis and high and lower steady-state hemoglobin, usually you need much higher doses to correct that.
Thank you, Dr. Yasser. Dr. Bakshi, a question coming from Palestine. He's asking about why we have these variations in sickle cell rate in Saudi Arabia, 24% in Al-Hassa, while almost 1 or less than 1 in the north. In Jazan it is high, so on. So why this variation?
Sickle cell diseases originate in the old oases. So the agricultural places where old agriculture was there and stagnant water. So in these areas that they have less, they don't have a lot of water. It is not agricultural area. It is mainly a desert. But when you see Jazan, Al-Hassa, Qatif, and Al-Qunfadh plus Khaybar, these are oases. And malaria was endemic. This is why I showed a slide to correlate between malaria, especially we are talking about falciparum, and the distribution of hemoglobin S. So in this area, it was the old agricultural areas, and those they have very less. They are non-agricultural areas in the past. That we are talking about 10,000 years ago, not currently. I hope I answered the question.
Thank you. The same asking about legalization of hemoglobinopathies. I think he talked about the premarital screening program. Yes, we do have it in Saudi Arabia. Another question about platelet factor 4 biomarker as indicator for sickle cell complication. This is to you, Munir. And the relationship with platelet factor 4 and COVID vaccine. So could be a contraindication for COVID vaccine in severe sickle cell anemia?
The true answer is I don't know. But when either the ASH committee or the committee, when they reviewed the indications and contraindications, they didn't put this as a contraindication for sickle cell disease, especially when they are in the steady state or quiet state of sickle cell anemia. People, they will not vaccinate people during the crisis.
Thank you. Dr. Yasser, what is the target hemoglobin level in sickle cell anemia patients?
This is a very good question and very important question. We noticed over the years that many patients in our region have got a low steady state hemoglobin. Actually, previously, we don't look into that as a serious thing, but with the very recent research and the highlighting the role of this hemolysis, we are now and the rate, the steady state hemoglobin. I personally feel if we can raise the hemoglobin level above 9, that will be a good target. So we have many patients with 7, 7.5, 8. I think these levels are not enough and not adequate because we have now large body of evidence that this low steady state hemoglobin might lead to early end organ damage. And mainly we have seen in pediatric age group the pulmonary hypertension. But as I highlighted, even the nephropathy, the brain, the vasculopathy, all can start quite early. So we hope the target for me, I should try as much as we can to get my patient above 9 with a low retics, and this is very important. So retics of 300, 400, 500 are really high, and we used to ignore them. Now I think we should be more careful about trying to reduce these reticulocytes to below 150 to be in the safer side for the future of our sickle cell. Thank you.
Thank you. Munir, what is the maximum safe hydration for children with vasoclose of crisis and to avoid the risk of acute chest crisis?
I understood the question. Are you talking about hydration status?
Hydration status, the maximum hydration in children.
I think the maximum IV fluid you should give to patients with sickle cell disease, the rate of the IV fluid to avoid acute chest syndrome.
This depends. If the patient is hydrated, you have to correct the hydration. Otherwise, the patient should take the maintenance as parenteral, and the rest he can take oral as long as the patient have good kidney function. But don't over flood the patient with too many fluids. So
okay.
In our center, actually, we if they have vasoclose crisis, we start 1.5 maintenance because the patient usually in vasoclose crisis they don't drink much, and then once the pain started to settle, when as you said correctly, when they started to drink, so we reduce to maintenance, and they can take the rest as oral.
Dr. Hafez, a question about when we screen for retinopathy in sickle cell disease, when we start screening, and the management of retinopathy if happened.
For sickle cell anemia, we do it annually. Every year, we send the patient to ophthalmology to screen for retinopathy. The incidence in our area is very rare, and when it is there, we maximize our management like hydroxyurea and blood transfusion if there is no response to treatment by ophthalmologist.
And the start is after the age of 10 years, so from the pediatrics. Plus, I think we should, the incidence is different between sickle cell anemia as homozygous S and sickle cell C disease, which are having more retinal problems because of retinopathy. Yeah, positive retinopathy.
Dr. Yasser, there is any correlation between LDH level and chronic hemolysis in sickle cell, either adult or pediatrics?
Yes, of course. The LDH, lactic dehydrogenase, is a marker of hemolysis, and usually in patients with low steady-state hemoglobin and higher reticulocytes, so the LDH will be increased. We have seen patients even above 1,000. So it's a marker of hemolysis. But Dr. Ahmed, if you allow me, I found a very interesting question here. Any idea about the time of preoperative transfusion, which changed, and the time of surgery? This is an interesting question. About the time of preoperative transfusion exchange, he means a preoperative exchange transfusion and the time of surgery. We do it 1 day before surgery, immediately, if there is a major surgery. But if the hemoglobin is high nowadays and the surgery is not a major surgery, we can go without any exchange transfusion. So someone with a hemoglobin of 10, for example, is fit to go to surgery without a preoperative exchange.
Thank you. A question to you, Dr. Yasser. Do you have guideline for sickle cell anemia in Oman?
Yes, we have our local guidelines combined by adult and pediatric hematology. We have our local guidelines.
Yeah. Hafez, a question about stem cell transplantation. Is it indicated in sickle cell patient? And what is the indication?
Yeah, it's one of the most curative therapy for our patient. The indication depends on the presence of major complication of sickle cell anemia, like a stroke or either thrombotic or hemorrhage or any other sinus crisis, acute syndrome that is recurrent and not responding to hydroxyurea, cardiomyopathy, like this AVN, that progressive AVN also is considered one of the indication. Reluctant, painful crisis, not responding to all modality of treatment, also is indication for bone marrow transplant.
Again, Hafez, do pulmonary hypertension in a lady whom she is pregnant an indication to terminate pregnancy?
No, unless it's so severe pulmonary hypertension, and from the question it seems that is maybe at the early stage of pulmonary hypertension. I don't recommend. I recommend optimize the medication treatment like blood transfusion, and I would weigh the risk with after discussion with Psengini. But generally, I don't recommend unless so severe.
Thank you, Dr. Yasser. In blood transfusion for sickle cell anemia, which is preferable, whole blood or backed RBCs?
Backed RBCs, of course. We do backed RBCs even for exchange transfusion, and then we can calculate the deficit. So nowadays we don't use whole blood. You know that the whole blood is antigenic. You have lymphocytes, you have neutrophils. You don't want all these cells to come to the patient. We prefer backed blood cell transfusion.
Dr. Munir, quickly about vaccination in sickle cell anemia children.
Sickle cell disease patients, they will undergo the primary vaccines. In Saudi Arabia, for example, we are giving all the vaccines except the pneumococcal polyvalent polysaccharide 23, which we start usually for sickle cell disease at the age of 24 months or 2 years of age. Then after 5 years, then it will be every 5 years from in the adulthood. Meningococcal conjugate, it is in the schedule at 9 and 12 months. But if we are using the conjugate, then it will be every 4 years or 5 years. If it is polysaccharide, then you need it every 3 to 4 years with the annual influenza vaccines. Hemophilus influenza and conjugate pneumococcal vaccine 13, it is already in the primary vaccines. So nowadays, most of the sickle cell disease children, they are well covered.
Thank you. Dr. Yasser, what other than penicillin prophylaxis for sickle cell anemia if penicillin is not available?
Okay, so there was also another question I have seen about the long-acting penicillin or the oral penicillin. Which one to use? Of course, it's very difficult to use the what we call the long-acting penicillin. It's intravascular. It's very painful. So we prefer to use the oral. If the child is sensitive to penicillin, we use the erythromycin, and this is the recommendation, sensitive to penicillin. And after the age of 5 years, as per the recommendation of the sickle cell study group, that we stop penicillin prophylaxis, we give, as highlighted by Dr. Munir, we give the second dose of the pneumococcal 23-valent vaccine, and we stop penicillin prophylaxis or whichever antibiotic prophylaxis for this patient.
Dr. Hafez, quickly, how we manage high-grade fever in sickle cell patient?
Fever is emergency of sickle cell anemia and should be taken seriously and should be managed according to other presentation, either fever with respiratory symptom, with abdominal symptom, or UTI. So it depends on other associated symptom, but generally should be admitted and managed very well and worked up.
Thank you. Dr. Munir, is it important to keep sickle patient on folic acid?
You know, because of the short half-life of sickle cell disease, we know that lifespan is 10 to 20 days in sickle cell disease, where the normal is 120 days. Because of the turnover, we need to have good folic acid for the production of the red cell. Otherwise, we will enter into a megaloblastic crisis and abolish the bone marrow from the production. So definitely we need the chronic use of folic acid.
Thank you. Hafez, a difficult question really. How you manage a patient whom he develops stroke after bone marrow transplantation, a sickle patient?
I never have such patient, but it's considered bone marrow transplant is a curative treatment for stem cell transplant. I think the ideal management the same, exchange transfusion if he still has high hemoglobin S, and we may look for bone marrow transplant status. Is he failed or he is in good status?
Also, sometimes they have chronic changes or chronic sickle cell vasculopathy in the cerebral blood vessels. So I think in these patients also better to get MRI angio to look into the cerebral vessel status. You may surprise to have a moya or something. So they might need even some sort of surgical anesthesia.
Yes, thank you. Thank you, Dr.
Again, Hafez, a question about periabism. Does it need to get regular exchange for those patients if persist?
Yeah, it's mandatory. I always ask about periabism in our patient. At the same for menstrual cycle. In the ladies, they shy to represent or express. For male patients, they shy to present. So it's not simply to get it as a common complaint. But when it is there, you should maximize hydroxyurea for mild forms. For moderate and severe cases, you need to start exchange transfusion or long-term therapy for 1 to 2 years, and then you reassess again. And if it is percent, you need to refer for bone marrow transplant.
Thank you. Another difficult question, Dr. Yasser. If somebody needs transfusion and has allo antibodies and all the bags we are screening, it is positive. So what shall we do in those patients?
It's a very difficult question. So the best answer is first, you have to avoid as much as we can the alloimmunization by doing the extended matching for the first transfusion. And this actually the main reason those who present for the first time with the need of transfusion, if you don't do the extended matching, sometimes they end up with the alloimmunization. We give the least incompatible. We give also hydrocortisone and sometimes IVIG. So we give the least incompatible with some sort of immune suppression like by the steroids. If he is really in need of blood transfusion and it is life-saving.
Thank you.
The use of erythropoietin plus hydroxyurea will maximize the dose.
But no, he's talking about life-saving. Because if we try to avoid this erythropoietin and hydroxy will take time to work. But life-saving situation, I think the least incompatible with the steroids.
Unfortunately, I have exceeded our time by 10 minutes. Still, there is some question we couldn't answer. But thank you for the attendees for your listening and keep with us up to this time. Thank you for our three eminent speakers, Dr. Yasser Wali, Dr. Munir Al-Bakshi, Dr. Hafez Malhan, and thank you to SSBD for this arrangement. Keep in mind these presentations is available on YouTube. You can go to it at any time, and please visit Salamat Dammak website. It is a new one. Thank you, everybody, and have a good night.
Thank you very much, Dr. Ahmed Tawawa, for your kind invitation, and for Dr. Hafez and Dr. Munir. نراكم بخير يا رب. بعيدا عن البانديميك يا رب إن شاء الله.
أنتم على خير إن شاء الله. تصبحون على خير.
شكرا دكتور حافظ. Enjoyed your presentations.
Thank you. Thank you very much.